Good afternoon, everybody, or good morning, good evening, depending on where you are in the world. It's 3 o'clock here in the UK, and time for the next IPC Journal Club. Delighted to have Jon on today, and Jon is going to be talking about Candidozyma auris, previously known as Candida auris, an emerging threat. Before I pass over to Jon, we're just going to run you through some of our housekeeping. So all of our journal clubs are recorded, and there's the opportunity for you guys to ask questions. Please use the Q&A box. It should be at the top of your Teams chat. Just an introduction to IPC Journal Club if you are here joining us for the first time. We run this every 2 weeks at the same time on a Wednesday, and our main outcome really is to try and provide insight into a topical IPC published paper. And I'm delighted to say that over the last couple of months we've had a really diverse number of speakers. We've had some special guests talking about biofilms, vascular access, and lots of different IPC challenges. And we're always welcome to guests as well. So if you'd ever like to get in touch about featuring on IPC Partners Journal Club, then you can do through our social media channels. Ultimately, we want it to be able to generate discussion, so we'd love to hear questions from the audience. And like I said, please use the Q&A box. We'd like it to be an opportunity for personal development and continuous CPD as well. And Jon and I like to think that we're trying to build a network of enthusiasts for independent research and study. And also we'd like to try and have a little bit of fun as well. So without further ado, I'm going to turn my camera off and pass over to Jon. Jon, over to you.
Okay, don't turn your camera off, Phil, because I need you. I need you to have a good. I need you to have a good whinge about something, and I know it's something that you'll relate to too, and probably pretty much everybody who's joined us today will relate to also. And it's this: Candidozyma. Why? I have a really big bone to pick with anybody working in fungal taxonomy who's made the decision that for reasons that are not clear to me, the organism needs to change its name. Phil, what do you think?
Well, I just spoke at a conference today in Birmingham, and I talked about this organism. And I managed to get it right. And I spoke to a couple of people afterwards, and they said, we didn't even know that it had changed names.
Yeah.
So I'd like to think that we're ahead of the curve in that sense. But it is a bit of a tongue twister, isn't it?
It is a tongue twister, to say the least. Okay, thanks, Phil, and good afternoon, everybody. So we're going to be talking about Candidozyma, and the controversy around the name doesn't end there either, because is it Candidozyma auris or is it Candidozyma auris? So the origin of the organism, and this is a bit of microbiological trivia for you, is that it was first identified in 2009 in a Japanese aural canal. So I think it should be Candida auris, but I do feel like I'm losing that battle because pretty much everybody else thinks that it should be Candidozyma auris. So I'm going to go with auris. I hope it sticks, but if it doesn't, I suppose I probably need to get over it ultimately. So today's going to be slightly different. I've got a fair amount of slides to get through with you, just to give you a little bit of background around Candidozyma auris. What is the issue around the epidemiology and current prevalence and some of the IPC practices towards the end. I'm going to try and do my very best to leave plenty of time for Q&A at the end. So do please get your questions into that Q&A box, because that's the best part of this journal club, is hearing from you and working through the questions that come through. So let's start with the microbiology. So it's a fungal opportunistic pathogen, formerly Candida auris, now Candidozyma auris. We know that risk factors for colonization are similar to other antibiotic-resistant bacteria. It's able to colonize humans as well as cause a range of infections. Antifungal resistance is a real problem, both in terms of the population at large, but also something that can develop during therapy as well. We've seen a global spread, and actually some of the data that you might read about clinical impact is alarming, with mortality figures in the sort of 30 to 60% bracket. But when we start to really delve down into attributable mortality, i.e. the kind of the risk of death in our patients that we can attribute to this organism itself, the data starts to look quite different, and we'll look at that data later. So from an IPC viewpoint, timely identification of colonization and rapid isolation are the mainstays of prevention, and we'll come to that at the end. So let's start with prevalence and epidemiology. So Candidozyma auris is broken down into 6 clades, numbered 1 to 6, all of which have a different origin and some different characteristics. Candidozyma has emerged really quite rapidly globally in the last 10 years or so, and has now been reported from at least 45 different countries. This is a global overview based on some very recent data that just categorizes the world into 1 of 3 boxes: detected, a series of outbreaks, or endemic. And we can see that it's certainly endemic in parts of North America, in South Africa, in parts of Asia, and in parts of Europe as well. I would also note there's probably chronic underreporting in many parts of the world as well for this organism. I think the USA actually presents a really nice test case for us to ask questions about the emergence and how have we got to this point. Because if we look at the number of isolates reported to the CDC, we can see a year-on-year increase significantly. I think there's probably some ascertainment bias in these figures. Data from the CDC website tracks the emergence of Candidozyma from 2016, where there were very few reported cases across the entire country, right up to last year, where the vast majority of states had quite a few outbreaks detected. If we look to the rest of the world, then there's even more data of rapid emergence. This is a recent study from Saudi Arabia, and you can see that green bar at the bottom of the stacked bar showing mainly Candidozyma auris went from 25 outbreaks at the beginning of the year right up to 90 in the majority of outbreaks by the end of the year. And that's just over the course of 1 year in 2023. Now, if you read that study, there's a little bit of probably reporting bias, because as they were rolling out this national program, the process for identifying the outbreaks became a little bit more defined. So to look at clinical impact in just a little more detail, as I mentioned, Candidozyma auris is an organism that can colonize, and it can also cause infections. So much like something like maybe CPE or MRSA, although it's a fungal pathogen and not a bacterial pathogen, it shares that ability to colonize skin without causing obvious signs and symptoms of infection. And from a microbial point of view, that's quite a helpful characteristic, because it allows it to spread under the radar with undetected colonization, resulting in cross-transmission. Invasive candidiasis and candidemia, so candida in the blood, can be a life-threatening condition, and I mentioned this crude mortality previously. But actually, when you look at data, especially from the UK setting, attributable mortality is certainly less than 30 to 60%, and in many cases is zero, in that we're seeing infections, but they're being treated, and if patients do die, sadly, then it's of some other cause. I think the main reason that we're talking about Candidozyma auris today, and why it's identified by the WHO as a priority pathogen, is because of antifungal resistance. It's not so much because of that immediate clinical picture that we might be more concerned about with other organisms. So most clades and strains of Candidozyma are already resistant to fluconazole, so we're limited in our treatment options right from the start. Antifungal resistance does vary by clade, and it can change during therapy. The echinocandins are the treatment of choice for most invasive infections, but are not always as effective. So it's a little bit like the arms race that we're used to understanding in the bacterial world, where there are treatment options down the line. It's just that they're not nearly as effective as the frontline agents that we'd really like to use, but we can't use anymore because of resistance. This is a recent study that looks at antifungal resistance rates across the world from a global set of isolates. And you can see there's pretty good global coverage there. I'm just trying to quickly see, have we got each continent reflected? I can't see. Yeah, I can see the Americas, I can see Asia, I can see Europe, maybe not Australasia. Anyway, it's a pretty good global collection of isolates, and you can see fluconazole is pretty universally resistant. Amphotericin B is following on that way, and even the echinocandins in some parts of the world, we're beginning to lose them. Now, I would say some of these data are dependent on the local testing methods, which may not be 100% reliable, but I think it gives you a good picture that this is an antifungal resistant organism, and it backs up these concerns that are being shared around the prospect of unmitigated spread and what that might mean for healthcare. So when we're looking at risk factors for infection or colonization with Candidozyma auris, they're similar to what we might expect to see for antibiotic resistant bacteria such as CPE. So that's things like advanced age, any kind of devices, especially mechanical ventilation, underlying medical conditions, surgical interventions, and various medicines as well, which include antimicrobial agents, especially antifungals, but things like steroids as well, can predispose colonization or infection with this organism. So moving on to IPC measures, who do we screen? Well, the evidence shows that patients who are infected are usually colonized too. So therefore, screening patients is a good way to identify fairly accurately who is colonized or infected and where your risk of cross-transmission lies. Recommended screening sites are disputed, I think it's pretty fair to say, and there's some evidence either way. But the latest guidance, certainly in the UK, recommends a pooled screen from the nose, axilla, and groin as the best way to optimize the detection of colonization. There is evidence that adding samples from the rectum, pharynx, urine, mouth, ear, vascular catheter sites, and wounds may also add sensitivity, but it's just not realistically feasible to have a broad screening program that covers all of those sites. We'd run out of time, and it wouldn't add enough value to justify it. What about screening staff? Well, Candidozyma auris has been found on the skin and the hands and in the nares of care providers, but routine screening is not usually recommended because most of the time that tends to be transient, and I think we have enough to go for in terms of preventing other routes of transmission, and outbreaks have been controlled successfully without resorting to staff screening. In terms of patients, common triggers for screening, and I'm thinking particularly at the time of hospital admission, would include patients who are previously positive. I think we can assume that they're colonized, but it's worth confirming that. Any patient with hospitalization overseas should be screened. Now that's slightly dependent on where you are working in the world, but certainly in the UK setting, I think anybody with overseas hospitalization should be screened. And I think direct transfers from known at-risk hospitals that maybe have an outbreak or have had a recent outbreak would make sense as well. And then the third major category of patients to screen is those who are being screened as part of a contact tracing investigation. So if there's an outbreak and you have a multi-occupancy bay, you find a new positive in the bay, then you've got a bay full of people who've been exposed to that organism and should be managed as contacts. How to screen? So Candidozyma can be misidentified quite easily. So moldy tough is the gold standard for identifying down to species level. So the advice is that Candida species should be identified down to species level wherever possible, and that will prevent Candidozyma auris masquerading as a Candida species that isn't identified down to species level. Now, it may not be feasible for every lab everywhere to identify a Candida down to species level in all settings, and we may have to prioritize where that's done. From a laboratory point of view, culture is the mainstay of identification, and there's some quite good Candidozyma auris chromogenic agar plates that seem to be working quite well. PCR-based methods are available as well, and obviously PCR-based methods are more rapid and more sensitive, but they're also more expensive and they don't provide antifungal susceptibility data either. So here's a recent study published a few years ago comparing chromogenic agar enrichment culture and PCR. A couple of takeaways here. As we would expect, direct PCR on the sample was sensitive and specific, and it had more sensitive than culture in terms of the limit of detection of the bacteria in the sample, of the fungus in the sample, down to 100 CFU per mil versus 1,000 CFU per mil for the chromogenic agar. Adding enrichment culture didn't add much value, perhaps surprisingly, but that's what the study showed. In more recent years, we're beginning to see some rapid molecular point of care tests coming onto the market. So these are tests that can be put in a hot lab or in a clinical area and give you a same day test result within a couple of hours, and that might be helpful in some settings for Candidozyma. What about the duration of colonization? Well, I think for now, it's once positive, always positive. That's the starting point until that becomes unworkable. The definition of colonized or uncolonized as a status is problematic, and the duration of colonization is unclear. Certainly, for the duration of a single hospitalization, I would be considering a patient to be colonized and managing them as such. And there's evidence that colonization continues for many months after discharge as well. This is a study that was done in the States, looking at a cohort of 75 patients who were discharged, an evaluation of when and if they became serially negative. So the time taken to become serially negative was, on average, around about 9 months. And it was around about 5 months on average to the first negative sample. So I think we can probably take from this that we ought to consider a patient who's readmitted with a previous positive test as a very high risk of being culture positive and a transmission risk, and isolate them preemptively and test them. What about decolonization? Is there effective decolonization? Well, I'm afraid the bad news is that for Candidozyma auris, there is no effective recommended decolonization protocol, as we do have for other organisms. There is a little bit of evidence that skin decontamination using chlorhexidine or related skin products doesn't decolonize the patient, but it does reduce the burden of colonization, and that might reduce the risk of cross-transmission. So this is a study that looked at whether a week of 4% chlorhexidine would decolonize a patient with Candidozyma auris over a cohort of 38 patients. By the way, 4% chlorhexidine, that's quite a high concentration to be having on your skin for an extended period of time in this way. 2% chlorhexidine would be more usual for this. But even with that high concentration of chlorhexidine, only 9 of the patients who were included in this study showed evidence of being effectively decolonized, and one of these became recolonized within the 30-day follow-up window. So pretty disappointing if your endpoint is absolute decolonization. If, however, your endpoint and your reason for reaching for the orange bottle, the chlorhexidine, is to try and suppress the amount of fungal contamination on the skin, and hope that will reduce the risk of cross transmission, then I think you're in business, because this is a nice study, and it shows that in a skilled nursing facility setting, in a small cohort of 10 patients, there was a significant correlation between the concentration of chlorhexidine on the skin itself and the odds of colonization of a given body site. So as the concentration of chlorhexidine got higher, the risk of contamination of that body site got lower. So I think there is some evidence that chlorhexidine might suppress colonization, and that might reduce transmission risk. In general, I think we should be applying transmission-based precautions for patients with Candidozyma auris. So that's single room with ensuite, preferable. Alcohol-based hand rub is fine, or hand washing for hand hygiene. We need to focus on note flagging and communication between different wards and clinical areas, and especially in terms of inter-facility transfer of patients. That's certainly an area where we've learned from the emergence of CPE in particular that we've got to get our communication between facilities right, if we're to optimize prevention. And I think there's good evidence that a real focus on device care is going to help prevent the transition from an infected, from a colonized patient through to an infected patient. And the final area I want to talk about today is cleaning and disinfection of the environment. So there's plenty of evidence that Candidozyma auris is very able to colonize things, be that the skin of a human or surfaces of medical devices or general surfaces in the ward. It has a capacity to tolerate salt concentrations and also to form biofilms, and those capabilities are likely to underpin this ability to survive in the environment. Consequently, widespread environmental contamination has been reported. This is a really nice study published from the States earlier last year. And what it shows is that around 41 patients with known Candidozyma colonization across 6 different healthcare facilities, cleaning disinfection was actually quite effective. So immediately after cleaning and disinfection, there was no Candidozyma auris identified on the surfaces. However, within 4 hours, 20% of the sites in the rooms that were sampled became colonized again with Candidozyma auris. So this is evidence of rapid shedding into the environment. And that was a similar trend for the other healthcare associated infection pathogens. And what about shared medical equipment? This is a seminal study published from the team in Oxford, and they found that an outbreak in the UK was linked to contamination of surface temperature probes. So here you can see in this case control study comparing 66 cases with over 300 controls. The auxiliary temperature monitoring probes had an odds ratio of almost 7. So patients who have been treated with these probes were almost 7 times more likely to be a case that is colonized or infected with Candidozyma auris than they were to be a control. And it's to reinforce that association. When the majority of the probes were removed, there was a pretty rapid reduction in the number of new cases. So that suggests to me that actually these temperature probes really were the main cause of cross-transmission in this outbreak. What about disinfectant efficacy? Well, this is a study that looked at the efficacy of various different disinfectants, chlorine, chlorhexidine, and ethanol. And you can see that even 500 parts per million chlorine, whilst it was partially effective or effective against most clades, it was found to be ineffective under dirty conditions. And we know that chlorine-containing disinfectants can struggle when it comes to soiling. This is another study looking at sodium hypochlorite and peracetic acid, so that the panels on the left show the results for sodium hypochlorite at various concentrations and on various substrates, and the panel on the right shows the same substrates and organisms, but this time with peracetic acid. And you can see that the peracetic acid, I think on balance, did slightly better than the chlorine, particularly on the polymer matrix. But that some of the strains of Candidozyma that were tested presented more of a problem than others. So there's some inter-strain variability in terms of disinfectant susceptibility. So where does this leave us and what should we do? I think now is a very good time to be looking at the latest guidance, working out what your local screening strategy is that's a good fit with your context, and making sure that the workforce is aware of this emerging threat. I think it's probably true that Candidozyma will be coming to a hospital more or less wherever you are working in the world today. And it is very much arrived in some places and is beginning to present some substantial clinical and operational challenges in those places. So with that, Phil, I'm going to stop and let's see what questions we have to talk about today.
Thanks a lot, John. Really enjoyed that. And, it's both worrying and challenging, the problems that are coming over the hill. I've just been talking today about the future of environmental decontamination. I spoke about Candidozyma, saying how it's an emerging threat. be switched on to how we tackle it. I guess some of the research that you showed, one of the most interesting things was me where you showed that slide where you showed the activity of the disinfectant worked really well initially, and slowly then the organisms started to grow back quite rapidly actually. And I still think that there's a role for biofilm within the environment, and I just wondered if you had a thought around whether or not what you think that mechanism of action is for those organisms growing back. Is it because we don't get the levels down to low enough levels to kill them and they just start proliferating again, or do you think there's something like a biofilm going on?
Yeah, I think there's a couple of different potential reasons why we see that rebound of contamination within the room of a patient. I think if it's sort of a daily disinfection approach where you're disinfecting the room as part of the daily process, but the room is still occupied by a patient with the organism, then it's most likely that the contamination after the cleaning and disinfection process is due to repeated shedding. And I think that was the case in this study that we've looked at. But we also see in studies done at the terminal point of disinfection, so when the patient is discharged from the room or the space, you do your cleaning process, you sample the environment, you still find contamination remaining. So is it that the disinfectant hasn't been distributed properly? Has it not had the appropriate contact time? Is it not the right disinfectant to work under those conditions? And I think biofilm is probably a factor that's hampering the ability to eliminate that contamination, especially at the terminal point of disinfection. As to what we might do to prevent that recontamination event, it's very difficult to know. I mean, maybe we just need continuous cleaning and disinfection around colonized patients, like a one-to-one allocation of a cleaner, a cleaning professional to the room of a patient with a known infection. That might be the way forward.
Yeah,
I'll have a chat with the board. I'll have a chat with the board and see if we can work it out.
We can only hope for something as good as that, can't we? But yeah, that's one of the reasons I said again this afternoon. Really enjoy working in this field is because there's always challenges and questions to try and answer. And I feel, we weren't talking about this organism 10 years ago. So we're always being challenged with new evolving threats. So just a reminder that people can ask questions in the Q&A. Oh, it's a great one here from Cheryl. Cheryl asks, what disinfectant product would you advise with all that in mind?
Yeah, good question. And I think the evidence is equivocal. We don't have the perfect evidence. With Candidozyma, we have less evidence than with many other organisms. There is some data that quaternary ammonium compounds have limited efficacy against Candidozyma and other Candida species. Whilst I think that is true, that needs to be interpreted slightly with caution, because I think if you test an individual quaternary ammonium compound in the lab versus a formulated product that has multiple elements to it, you might see a quite different result. That said, I think there probably is enough evidence to move to the kind of sporicidal level of efficacy when you're dealing with Candidozyma auris. So it's not that it is a sporicide, or in a lab setting there are other products that would work, but personally I'd go down the route of a sporicidal level agent. Chlorine is an option, and lots of recommendations say chlorine as a first option. My own view is that chlorine isn't usually the best approach. It gets broken down really quite quickly when it comes into contact with physical contamination, which is something that's all around us in the ward environment. So I think something like peracetic acid or maybe a hydrogen peroxide based disinfectant would be my first choice.
Okay, thanks, John. Maybe just building on from that, in terms of where you would put terminal clean, in your organization's cleaning policy, if you think about going from, let's keep it simple, green, amber and red. If you've got a patient who's infected or colonized and they're being discharged from a side room, what kind of clean are you putting in that?
Is red the big guns?
Red is the big guns, yeah.
Red is the big guns. I'm going like the darkest red you've got. I think the evidence shows that Candidozyma really does contaminate the environment. It's shed pretty broadly via skin, the skin squames that come off us all the time. So yeah, I really do think that we need to reach for the top shelf, as it were, from an environmental hygiene point of view.
So for me, red would be in with my C. diffs,
Yeah.
my CPEs.
Yeah, exactly right. And
Yeah.
for that reason, I'd be looking at hydrogen peroxide vapor room disinfection as a kind of belt and braces when we've had a discharge with Candidozyma for sure.
Yeah. Okay.
So Phil, back at you then, Phil. What would you say to the same question about which disinfectant you choose?
I think I'm on a similar page to you. I think that given, the risks, and maybe just something in my mind around how we're still learning about this organism, we're clearly worried about what it can do in terms of rapidly colonizing our patients, and actually, when they do get colonized, how difficult it is to eradicate that colonization. I think I'd want to be throwing everything I could at the environment. I'm definitely putting it in the same box as you in that red clean space. And I'd definitely be thinking about, something along the lines of what I'd be using for my C. diff. There's something sporicidal. Um, Again, I've got issues around chlorine and whether or not it's working in dirty conditions. But yeah, I'd like to see something around a really high level disinfectant, which is going to give me good efficacy, good contact time, achievable contact time. Maybe in an ideal world as well, if it wasn't a terminal clean, it'd be something along the lines of just an increased frequency of cleaning, because like you just alluded to, that shedding of the organisms from the patient into the environment, and then the potential then for cross contamination. So yeah, in the same camp as you really. Okay, back to the questions. Isabel asks, John, is there any risk of airborne contamination? It's a great question.
Yeah, it is a really interesting question. So I think airborne transmission in the traditional sense of a pathogen that enters the body and causes disease via the respiratory tract, I don't think Candidozyma is going to be doing that. It's spread via contact routes, and the portal of entry into the body is not the respiratory tract. So in that sense, it's not following a respiratory trajectory from patient to patient. Could the air be a vector for part of that transmission cycle? Absolutely, yes. So we could have skin squames that are contaminated with Candidozyma auris that come off the body, float up into the air, and are transmitted via the air to the hands of healthcare workers or to the surfaces of equipment, or perhaps even remain in a room that a new patient is then admitted to, and contribute to cross transmission in that sense. So through the air could be a mechanism by which contamination spreads, but it is via the contact route, if that makes sense. Did that make sense, Phil?
It did, in a roundabout way.
Yeah.
I just want to check you can hear me okay, because somebody said in the chat we can't hear you that well, but I can hear you perfectly.
Yeah, you're a bit wobbly, Phil, but it's okay. It's fine.
Okay, apologies for that. Another question, John, if that's okay. Pronunciation of names is dreadful. I think it's Moira asks, is there any evidence yet in relation to UV? So I think that's asking whether or not UVC is active against this organism.
Yeah, I think that there's a few studies that show that UVC at the sort of 254 nanometer wavelength is effective against Candidozyma auris. It's not going to be as effective to the same level as HPV, but it will reduce the level of bioburden. So I think whether you choose hydrogen peroxide or whether you choose UV may depend slightly on your context, but both processes need to follow effective, good quality cleaning and disinfection, because neither are designed to do any kind of cleaning of surfaces. It's only an extra level of disinfection.
Yeah, that's a really good point. And I think there's a whole debate there within UVC and HPV, isn't there? I mean, there's lots of benefits and downsides to both technologies. But I think if you think about how I've got to use HPV in my organization, I can't have, I've got to have a big downtime and a big dwell time. That perhaps UVC a bit more frequently, not giving me the same log reductions, but still giving me some kind of efficacy. I mean, we know that if we keep our distance relatively small between the device and the surface, that we can still get some good log reductions against things like C. diff. So I think, in terms of a lab test efficacy of UVC against Candida. There we go, I slipped into it. It's going to be there. We know that UV can work really well against other fungal pathogens. I think that the exposure time you're going to need for fungal pathogens and spores is going to be much higher than some of your vegetative bacteria. Okay. There's another question around decolonization process for patients, John, which you touched on a little bit around chlorhexidine. But yeah, what's your approach to decolonization of patients?
Yeah, it's a good question. I think we probably need to be quite careful with our language and how we're describing this, because we often talk about decolonization, and chlorhexidine bathing is kind of very closely linked with the idea of decolonization, because that's what it can do with other skin organisms like MRSA. With Candidozyma auris, that's really not what I'm seeing from the literature. There is no effective decolonization protocol for Candidozyma auris, but there is some evidence that things like chlorhexidine can reduce the burden of colonization on the skin, and that may be helpful in preventing cross-transmission.
Okay, so still kind of an emerging area and still a little bit of work to do.
Yeah, we do need more studies on that to be sure, either way, because there's some potential unintended consequences of chlorhexidine daily bathing. It can dry out the skin. It may even result in more shedding of skin squames. So I think it's in the balance at the moment, and that's reflected in the guidance on this issue.
Okay. Another question, this is my own, and just thinking a little bit outside the box. And I think this applies to the environment as well. If we're potentially dealing with biofilm, I've been always thinking about, do we need to alter the way in which we clean that surface? So do we need to think about changing the substrate that we use? Do we need to be able to generate potentially more friction, or more physical removal? So do we need a texture in the product that we use? I just wondered if you have any thoughts on whether or not, if we could potentially modify the substrates that we use in some of these applicators, that might make a difference.
Are you thinking like a little rotary hand sander that you go around the hospital doing your cleaning with? That might do the trick.
The minute I finished answering that question, I thought, well, it's just going to go and damage all of the equipment. So I'm not talking about getting a sanding block and a piece of sandpaper. I'm not talking about anything. But I think, when I think about biofilms, I think about this massive cellular matrix, but they're still just microorganisms at the end of it. So I'm sure that if we could put some textured element that is going to maybe help lift the organisms, or maybe puncture through membranes, things like that. But yeah, you've got the gist of it.
Yeah, there's a real potential here, isn't there, for some applied research, bringing in our materials science colleagues, because there's probably some really clever surfaces and surface finishes that might be applicable to reduce to apply to the surface itself, but also to use to clean the surface, to optimize the removal of pathogens, but also the functionality of the surface.
I'll keep going, John, because there's plenty of questions to go. We've got about 5 minutes left.
Great.
Somebody asks around the potential use of octenidine or actinisan. Any comments on whether that will be used for decolonization?
Yeah, I think I'd probably align it with chlorhexidine. I mean, I know it's a different chemical, but it's broadly similar in terms of the level of microbiological activity. So I think if we're seeing chlorhexidine not effectively decolonizing patients with Candidozyma auris, I'd be very surprised if octenidine did. But equally, if we see chlorhexidine suppressing colonization in a useful way, we might see the same thing with octenidine.
Okay, and maybe this might be the last question before we wrap up, or any final thoughts. Cheryl asks, can we allow patients to attend therapeutic interventions in a community mental health setting? So I think Cheryl might. Yeah, go on. Sorry, John.
Yeah, it's a really good question, and I'm presuming this is a patient with known Candidozyma auris or a history, colonization or a history of that. Yeah, I think as things increase, we're going to have to normalize the management of patients with known Candidozyma in many of our settings over the coming years. So the general answer to that sort of question is, well, what do we do for patients with other known infection risks? So, for example, if we had a patient with CP colonization, or we had a patient with MRSA colonization, how would we manage those in an outpatient group therapy setting where we have different transmission risks to an inpatient setting? The patients are generally clothed and they're taking care of their own hygiene. So in that sense, the risk of cross transmission is lower. So I think I'd be supportive of finding a way to support some kind of group therapy session. And equally for our inpatients, they need to have rehabilitation care. So we can't isolate them in a single room forever. We do need to give them ongoing care as well.
Okay, really thorough. Thanks, John. John, do you mind just bringing up the final closing slides, and I'll just talk to this last question.
Of course.
Beatrice asked, we've been asked or approached by many commercial companies for using portable fogging machines. Do you have any experience using those for terminal cleaning? Some of them claim to be able to be used in patient bays. I mean, I can start on this because I've seen some similar things going on in terms of fogging machines that can potentially be used around patients. And these aren't employing the typical disinfectants that we see when it comes to fogging, so things like hydrogen peroxide vapor. From my experience, these tend to be using a chemical which is actually generating quite a lot of interest in the infection control industry, which is hypochlorous acid. And hypochlorous acid is made through the process of an electrolysis reaction where you have salt and you do a chemical reaction using electricity. You generate hypochlorous, so it's very kind of naturally derived. And hypochlorous is being used in lots of different applications. It's used in wound care. It's used in, on skin. So I have seen some companies claiming, these fogging machines can be used while people are in the room, but I'm very skeptical. I don't think I've seen enough evidence. I mean, the chemistry and the concept of it being used for other applications outside of just environmental decontamination does seem to make it like a good fit, but we don't have anywhere near the evidence that we've got for HPV or even UV when it comes to their use for terminal disinfection. I don't know if you want to add anything, John.
Yeah, I'd like to actually, because I think there's a bit of a sort of biological implausibility here, as in if a chemical has the ability to inactivate microbes on a surface and if you're using the air as a vector for that, then I can't see a way that that's going to be safe for humans to occupy that space. So for me, terminal disinfection using fogging is for unoccupied spaces. I haven't seen any evidence that's convinced me that that's not the right approach. And then we can focus on applying chemicals to a surface using various modalities, be that a mop or a wipe or whatever, for disinfection of occupied spaces.
Great. Well, John, I always enjoy our journal clubs, and the discussion was brilliant on that one. We had loads of questions, so thank you to all the audience, and thanks, John, for your presentation. It's really, really interesting.
Thanks, Phil.
We've got a really exciting next couple of weeks for IPC Partner Journal Clubs. Our next one is in collaboration with the Infection Prevention Society. John and I are going to be talking about 2 papers that have recently been published in the Journal of Infection Prevention. So that's on the 2nd of April. And then I'm thrilled to announce that we've got our first sponsored journal club in partnership with ARCA, looking at gloves, when to use them and how to choose them. And we'll have Jude Robinson helping us on that one. We've also then got some dates potentially lined up with the Hospital Infection Society, the Healthcare Infection Society. Just a reminder, you can view all of the recordings on our YouTube channel. You can also see the full schedule of all journal clubs for future on our IPC Partners website. So, John, thanks again. Great to see you, and thanks everybody for listening.